Good evening and welcome once again to this series of lectures we've been having during the lockdown period. We started with the gas insufflation-less laparoscopic surgeries, or in short, what you call as GILS, because we thought it is very relevant during the pandemic because it's not a positive pressure system, it's a isobaric system, and there's no spread of the virus. And in addition, it's almost as good as regular laparoscopic surgery and at a much lower cost. When we started doing this many years ago, we were doing it primarily because it is less expensive, it's possible under spinal anesthesia, and we're able to do it in rural areas. But then now we realize that because of the lockdown and the problem with the virus, it's even more relevant, not only in rural areas, even in urban areas. But we thought the lockdown will be there only for a few months. So we finished the series, almost 12 lectures on gasless laparoscopic surgeries. Then we went on to rural urology lectures. Here again, we realized that many of the surveys that we did in the rural areas in India, we found that up to 5 to 10% of the patients who present to any outpatient clinic have urology problems. And half of them can be very comfortably treated with a little bit of knowledge. And the low cost, very inexpensive laptop cystoscope that Keshav was helping us to develop. With that, we can treat almost half the patients. But now today we are going back on laparoscopic surgeries because this is another important lecture that we, in fact, forgot about, and many of the people who are listening reminded us. This is about cleaning and sterilizing the laparoscopic equipment. We are very happy to have Daniel Robertson from Delft University with us. He came all the way from Netherlands to travel with us to the remote areas that we are working. And unfortunately, before he could complete his work, he had to get back because of the pandemic. But then he had some idea of what we are doing and how we are sterilizing. And we ourselves are surprised that what we thought was sterile is no more sterile. And it is very important to have a sterile atmosphere in the theater. And even in urology, we have sepsis, it can be very serious. So we'll listen to him first, and later on, we'll take questions. I hand over to Daniel now to start. Thank you.
Thanks very much, Dr. Nanraj. Let me just share my screen. Okay, so thanks, Dr. Nanraj, for giving me the opportunity to have this presentation. As Dr. Nanraj said, I'm Daniel Robertson. I'm currently a PhD student at the Delft University of Technology in the Netherlands. And I got to know Dr. Nanraj in 2019 because we're interested in the same topics. So the topic of my PhD is seeing how we can make laparoscopic surgery more suitable for rural settings. And Dr. Nanraj invited me to India twice. And during both of these visits, we started to notice that the sterilization of laparoscopic instruments could give some problems. So the methods that we saw could give some problems. So what will I be discussing in this presentation? Well, as said, in March, I went to India with Dr. Nanraj, and we studied the actual reprocessing methods of laparoscopic instruments in these rural hospitals. And I would like to present some of these findings just to see if the settings that we saw in rural India might be similar to the hospitals that you're working in. Then I'll be making some suggestions on how you could improve the reprocessing of the laparoscopic instruments. The situations that we found in rural India might be different than the setting that you're used to, but hopefully you'll learn a lot of new information as well. Many of the suggestions I'll give come from sources like WHO. So at the end of the presentation, I'll show you where you're able to find more information if you're interested in the topic. There are a lot of sources which are publicly available, and you can find everything online, from how to construct a new sterile processing location, and find information about all chemicals that you would like to know about. So first of all, what is reprocessing? Now, reprocessing is the whole cycle of that happens between instrument use, cleaning, disinfection, and sterilization. Now, cleaning is defined as actually removing the soil that's left on the instruments after use. And cleaning is the most important step of the reprocessing cycle. Then you have disinfection, and disinfection is the thermal or chemical destruction of the microorganisms on the device, but it's less lethal than sterilization. So it reduces the number of microorganisms on the device until it's safe to handle. And then you have sterilization. So sterilization destroys all microorganisms up to bacterial spores. So why should we actually look into reprocessing? Now, for one, as you're all surgeons, you know that surgery in general is a really good investment. About 30% of the global disease burden can be attributed to surgically treated conditions. And investing in surgery leads to actually significant economic growth. But surgery is also becoming more advanced every year. And with the advancements in surgery, the instruments also become more advanced. And now the laparoscopic instruments that we're talking about today are complex devices that cannot be sterilized with the same methods as regular surgical instruments. Now, providing surgery always comes with risks of healthcare associated infections, or HAIs. And the process of sterilization and decontamination are very complicated, and they require specific infrastructure and equipment that need to be correct in order to perform it safely. Now, some of the infections that can occur can be anything from surgical site infections to hepatitis, HIV, and other infections. And even with antibiotics, infections can still occur, and even improper reprocessing can even lead to hospital-wide outbreaks of bacteria, giving a really big problem to everyone. And it's not only a risk for patients, but also risk for staff. Now, the other thing is that when I was in rural India, I sometimes got the idea that the problem of antimicrobial resistance was not seen to be a really big issue. And the problem is that I was talking to a surgeon that operates both in a small rural hospital and in a large tertiary hospital. And as soon as a patient undergoes surgery in a rural hospital and gets an infection, what happens a lot is that either the infection cannot be treated in the rural hospital and therefore needs to be moved up to the district hospitals. And it's mostly in the district hospitals and tertiary hospitals where they face major problems with multi-drug resistant bacteria. So the reprocessing methods that you use in the smaller rural hospitals definitely have an influence on national healthcare level. Now, what makes reprocessing in the smaller hospitals different than reprocessing in larger urban centers? Now, besides that, the smaller rural centers probably have more financial limitations. There are a few extra barriers. Now, one of them is that reprocessing is a very complicated field, and in a lot of countries, it's defined by having standards like ISO standards. But in a lot of low and middle income countries and in rural settings, these standards are not yet available or are still being developed. And these standards are also quite difficult to apply because the standards generally are written to be able to get the highest quality in safety and care. But that makes them also difficult to directly apply to small hospitals. Now, the other one is that being in a rural setting also influences how much knowledge is transferred. So hospitals in an urban setting, there's often more rotation of doctors, of staff. So when staff or a surgeon learns something in one hospital about reprocessing, you can transfer that to another one. But this transfer of knowledge is less easy and slower in rural hospitals. And the last big difference is industry networks. The industry with medical companies are becoming quite a driving factor in deciding the methods that have to be used to clean their instruments. And these companies will often provide training and they will come around to hospitals to show what kind of methods can be used. But rural hospitals often lack the access to these industrial networks. So getting new information is often a lot more difficult. Now, I'd like to show some of the results of this study that we performed when Dr. Nanraj and I were traveling through rural hospitals in India. And during the study, we did several things. So we made observations of the reprocessing methods that were executed. And we talked to surgeons and nurses about the methods that they were using. We also performed measurements on the autoclave to see if they were suitable to reprocess laparoscopic instruments. Now, as Dr. Nanraj said in his introduction, I was in India in March, and that's when the pandemic was just ramping up. So we were originally going to go to 8 hospitals, but we eventually managed to go to 4 rural hospitals. But in those 4 rural hospitals, we were definitely able to see similarities in the way the instruments were reprocessed. And during the study, we also specifically looked at how laparoscopic instruments were reprocessed. Now, some of the findings were that most of the cleaning in all of these hospitals were performed by the nurses. The nurses that worked in these hospitals were trained by their general nursing degree. And every time when they moved to the rural hospital, they only knew about cleaning and reprocessing the general surgical instruments. And when they went to the new hospital, they learned they learned about the methods that were used in the new hospital where they went to work. But it also meant that there was no new training introduced about reprocessing laparoscopic instruments. What we saw was that the nurses have to work very hard during surgery. So the nurses had to have about 30 to 45 minutes between patients, between surgeries, to not only reprocess the instruments, but they have to, after surgery, they have to move the patient into recovery. They have to clean the operating room. They have to prepare the new patient, and they have to clean all of the instruments. Now, as I said earlier, the laparoscopic instruments are very complex devices, and they need time and expertise to properly clean. And this means because the nurses have to do all of the tasks between one surgery and the next, it means that they have very little time to properly reprocess all of the instruments. Now, because there was quite limited time, the instruments were not reprocessed in spaces that were dedicated for it. So a lot of the times, the instruments were moved outside of the operating room to a sink. And even in hospitals where there were dedicated sterile processing departments, they were not moved there just as a measure to save time. The other thing is that for a lot of these hospitals, the laparoscopic instruments are very expensive. And because they're expensive, there's often only one instrument set. So this one set has to be used in one surgery and then be directly used in the surgery afterwards again. And this means that some choices were made in the reprocessing of these laparoscopic instruments in order to be able to use that one set of instruments over again. And that means that a lot of the times chemical disinfection was chosen over sterilization. And the other concept that we saw is that because the instruments were so expensive, the staff was very worried that they would damage the laparoscopic instruments. Both the surgeons and the nurses thought that if instruments were sterilized by steam, it would damage the instruments. So that's why chemical disinfection was chosen a lot. And the last observation that we had is one about responsibility. So the nurses were responsible for cleaning all of the instruments, but they would also look to the surgeon for instructions on how to clean the instrument. So if they didn't know something, they would often ask the surgeon on how to clean it. And during the interviews, I asked some of the surgeons about the methods that were used for reprocessing the instruments in that hospital. And the surgeons often knew about the reprocessing method and thought it was a good method. So unless the surgeon in the hospital knew that something about the method was wrong, there was no one that would tell the nurses that they would have to look for a different method. So it's a question of responsibility. Now, here are some of the pictures that we took while visiting the hospitals. These are often the places where the instruments are cleaned. These are sinks which are close to the operating room so that they can be cleaned very quickly after surgery. The instruments are cleaned under running water. Mostly there were no correct brushes that are required to clean the hollow instruments. And there are also no instrument-specific detergents that were used for the instruments. And the other observation that we had was about the drying of the instruments. So a lot of the time, directly after cleaning, the instruments were placed into the disinfectant. So they weren't dried at all. And sometimes if the instruments were needed the following day, they were placed on the cloth to air dry. And also in this step, we didn't see anyone perform a careful inspection of the instruments. And the other observation that we saw was that, as I mentioned before, the laparoscopic instruments were mostly treated with high-level disinfection instead of steam sterilization. So there are only disinfectants used. And I will explain some of this later, but these disinfectants need careful monitoring and checking to see if they are still effective. But no one really knew about this, and there was no knowledge about the limitation of these disinfectants. Okay, so now I will go a bit further into the steps of the reprocessing cycle and what improvements you might be able to make. Now, the circle you see here is the entire circle of reprocessing. So reprocessing means all of the steps between use, transportation, cleaning, disinfection, inspection, packaging, sterilization, transport, and storage. The steps that I will mostly go into are cleaning, disinfection, inspection, and sterilization. Now, as you will find out from the next slides, I will start presenting a lot of information. But actually, the topics that I will talk about only present some of the most basic information about reprocessing. Now, to run a successful sterilization department, much more specific information is needed to learn everything to safely reprocess the instruments. Now, it's important for you as surgeons to be aware of the background of reprocessing, but because it's so much specific information, you probably don't have the time to learn all of the necessary information. So we need specific staff members that can learn more about reprocessing. So again, it's a point of responsibility. So ask yourself and around in your hospital, who should be responsible for learning about this reprocessing? And perhaps you can assign a nurse or a technician who will be responsible for getting new information and sharing that information to other staff. Now, one very big recommendation I can already give is that it really helps to develop checklists and procedures and standard operating procedures to to clean all of the different pieces of the equipment. So as soon as one staff member has found out, this person can develop checklists, and in that way, the reprocessing of all of the instruments can be standardized. Now, reprocessing ideally needs to be done in a dedicated space. By working in a dedicated space, it doesn't only improve patient safety, but also the working conditions for the staff. Now, even smaller hospitals can take measures to improve the location where the instruments are sterilized. And one of the most important aspects about this location is that it should be a space where instruments can be processed in one direction. So the dirty instruments get brought in after surgery, and in one direction they move through the whole space until they are clean and sterilized, and then they're moved away. Now, by working in one direction, it prevents cross-contamination of the instruments that were already sterilized. And in this, by having a dedicated space, it also provides an environment where the staff can take the time to properly inspect the devices. Now, there are two things that are very useful in a sterile supply department in the reprocessing of laparoscopic instruments, and one of them is having compressed air, and one of them is a water jet, and I'll explain that a bit later further on. Now, the other very important thing is personal protection for staff. And in all of the hospitals that we visited, the hospital didn't have any additional protection for staff besides surgical masks and latex. While scrubbing the instruments, you generally use a brush, and the debris can splash, and even microbes can become aerosolized. So proper splash masks for staff are really important. And this is the same for waterproof gowns. And the other one is having suitable gloves for reprocessing. So some of the disinfectants and detergents, like enzymatic cleaners, they will actually start to dissolve the latex gloves. And also when handling sharp instruments, it's recommended to have a thick pair of gloves. Now, the first step after when the instruments are to be transported to the location where they'll be reprocessed. And the most important thing is to keep the instruments moist after using them. And this prevents the proteins and fats from drying onto the instruments, and that makes them much harder to clean. Now, it's best to use an enzymatic soaking solution. And this soaking solution has enzymes that will already start to break down some of the proteins and fats that are left on the instruments. Now, if this solution is not available, just plain water should be used. Now, ideally, you would have a waterproof box that you can transport the instruments in. And it's best to cover them in a damp towel, because if you only cover them in a soaking solution or water, it means that while you're transporting them, the liquid can splash out and cause contamination elsewhere in the hospital. Now, the other point is that in a lot of hospitals, chlorine is still used as a soaking solution after use. And this is generally done to disinfect the instruments before they are reprocessed. Now, bleach and chlorine are no longer recommended because they cause instrument corrosion. And actually, I have an example of that. Now, this is a surgical instrument, and on here you can see all of these black spots. And these black spots are caused by corrosion of the instruments, and debris can build up in those pits where corrosion has occurred. And this actually, by using chlorine, it actually means that you'll have to replace surgical instruments more often, and it's very makes it very expensive. Now, the other disadvantage of using chlorine is that it deactivates the detergents and disinfectants, so the rest of the steps become less effective. Now, after transport, we have to clean the instruments. Proper cleaning is by far the most important step of the reprocessing cycle. Now, why is it so important? Well, the goal of cleaning is to reduce the bioburden and microbes on the device so that they can eventually be safely disinfected or sterilized. Now, when these devices are not cleaned properly, bacteria can settle on the instruments and eventually biofilms can form. Now, biofilms are a colony of bacteria that have a very strong protective layer, and this protective layer makes it about 1,000 times more difficult to disinfect and sterilize the bacteria than when they were just free floating. Now, the other point about cleaning is that it has to be done well, because some of the disinfectants, they will fix proteins onto the instrument and eventually make it harder each time for the instrument to become clean. Now, some of the disinfectants that do this are glutaraldehyde, for instance. So proper cleaning really is crucial for having safe instruments. Now, when I was in India, we have two examples here of instruments that weren't cleaned properly. One of them is a trocar port, and the nurses forgot to clean the debris under the flap valve. And every time you take out an instrument or reinsert an instrument, you would take some of this debris into the peritoneum. And the other example is here, which is the tip of an instrument. Now, you see that the teeth of this instrument have become completely brown. And this browning is caused by the fixing of proteins by the disinfectants used. So disinfectants like Sidex or glutaraldehyde will fix the proteins onto these complex surfaces and make it more difficult to disinfect and sterilize every time. Now, ideally, an instrument like this should just have a clean, only metallic color. So this brown color, which is on there now, shouldn't be there. Now, in cleaning laparoscopic instruments, we can generally divide it into two main methods. We have manual methods and we have mechanical or automated methods. Now, the automated methods are generally things where you need a washer and disinfector machine or ultrasonic cleaners. Now, these machines, they make the cleaning of the instruments much more effective. But because we're focusing on rural settings, I'll focus on the manual methods. Now, first of all, it's important to select the correct cleaning agent that you will use. A lot of the cleaning agents are, it is possible that the cleaning agents are defined nationwide, so that your country might already have some standards when it comes to the cleaning agent. But generally, these cleaning agents can be divided into two types. You have the enzymatic solutions and you have the detergents. Now, I talked about enzymatic soaking solutions before, and what happens is the enzymes in these solutions, they will break down some of the proteins and the fats and make the bioburden easier to get off the instruments. Now, the other ones are the detergents, which are more like soap. And these soaps, they make it easier for the water and the enzymes to penetrate into the dirt that's on the surface of the instrument. Now, one important thing is that these cleaners are not disinfectants. They are there to get all of the debris off, but they don't actually kill any of the microorganisms. So after cleaning, you still have to be very careful about infection. And the other one is it's very important to look for the manufacturer's instructions when using some kind of cleaning solution. So the manufacturer will give instructions on in what temperature it should be used, at what dilution it should be used, and how long instruments should be soaked for the cleaning agent to become successful. Now, when we were in the rural hospitals, some of the we saw different substances being used to clean the laparoscopic instruments and general instruments as well. And some of the substances can actually cause more damage onto the instruments than that they help. So one of them, for instance, is saline. Soaking instruments in saline will cause corrosion. We already talked about the fact that bleach shouldn't be used. Iodine preparations, abrasive cleaners, laundry detergents, we saw a few, surgeon hand scrub, and regular soap. They all can be damaging for the instruments. So when looking how to clean the laparoscopic instruments, we have a few different types of instruments. From bottom to top, we have the very first generation of laparoscopic instruments, and these were not really designed for easy cleaning. So these devices make it very difficult to properly clean them. And then we had the second generation of laparoscopic instruments that had a cleaning port fixed onto the device, and this cleaning port made it easier to flush soil out of the instruments. And then we have the third generation, which is the most modern generation. And these are instruments that you can completely take apart so that you get access to all of the surfaces that are required for cleaning. Now, this disassembly is very important because the pressure inside of the patient's abdomen actually forces fluids and blood up in through the shaft of the instrument. So only by disassembling the instrument, we can get to all of the debris. Now, as in the explanation about the biofilm, we need brushes to reach inside the whole lumen to brush out all of the waste. And it's important to fully disassemble the instrument. Now, ideally, we also want to brush the instruments while they're being submerged. If you brush the instruments, for instance, on a running tap, they can produce aerosols and splashing, and that increases the chances of cross-contamination. Now, you want to use a soft nylon brush on the instruments, and a toothbrush is fine. And you use a brush for the outer surface of the instrument and to get into the mechanism and the tip. Now, for the lumen, so for the long hollow part of the instrument, we need a specific brush that can run right the way through. So when inserted into the back of the instrument, it would reach outside into the tip as well. One thing we also saw was that there's a high use of reprocessing disposable instruments. Now, reprocessing disposable instruments happens all over the world, but one thing you have to consider is that these disposable devices are not designed for cleaning. So generally they are very difficult to clean. And this difficulty in cleaning also makes it very hard if you have a very limited time to clean the instrument. But one thing that really should be developed is that we need a very clear protocol for cleaning each device. Now, the difficulty in cleaning can be seen, and this is one nurse who's demonstrating how to clean a ligature instrument. And he actually needs to use a needle to get into the groove. Now, I'm not actually recommending that this is the best method for doing it, but we need a very clear protocol on how to clean these devices, and that protocol must be validated. So it should be checked. If you want to reprocess a device, really think about all the steps you have to take to safely reprocess it. And one thing you could look into is that there are some companies that offer reprocessing services of single-use devices. So you can send your ports or electrosurgical devices to them, and they will reprocess it for you. Now, the next step after drying, after cleaning, is drying. And the aim of drying is that it reduces the microbial growth after cleaning. And you'd want to dry your instruments using a clean cloth, and you can use compressed filtered air to dry the lumen of the instrument. And this is why we suggested having compressed air in your reprocessing facility. Now, drying is also important if you want to inspect your instrument after cleaning. And the last important aspect about drying is that if you're using any type of liquid disinfectant after the cleaning step, when you're adding wet instruments, you're continually adding dilution to the disinfectant, and it will reduce its effect before the manufacturer's date. So what should we look for during inspection? In the rural hospitals that we visited, the nurses got almost no time to inspect the laparoscopic. Now, as we mentioned, laparoscopic instruments are very complex devices with hollow parts. They have hinges and they have connections between different materials, which makes them very difficult to clean, and this makes inspection very important. Now, inspection is also very important because cleaning often doesn't have a very good verification. So there's no simple checks you can perform to see whether you're continually cleaning your instruments correctly. So every instrument has to be inspected before it's disinfected or sterilized. Now, a few of the aspects you have to look for are bioburden in between the tip. You have to check to see if the mechanisms are clean. You have to check whether the mechanisms in the tip or in the hinges don't have cracks. And one of the most important things is we have to inspect the insulation on the shaft. You as surgeons will know that using electrocautery is very important. But the problem in laparoscopy is that if the insulation on the shaft is damaged, the electricity in electrocautery can leak out somewhere outside of your field of view, and it can cause very severe burns in the patient. Now, the damages that these damages in the insulation can be often very, very small. So they can be hairline cracks, they can be small holes, and a very good way of testing the insulation is with a simple device called this insulation tester. And what this tester does, it runs on a 9-volt battery, and you connect the tester to the laparoscopic instrument, and you run it along the insulation. And when the insulation is damaged, it will give a sound if it's damaged. Now, instruments that have damaged insulation should either be re-insulated, which is a step you can get performed at certain companies, or they have to be discarded. We saw a few times in some of the hospitals that instruments that had damaged insulation were used for parts of the procedure that you were not going to use electrocautery on. But the problem with this is that if you have a cracked piece of insulation, you can get microbes that will grow within the cracks and under the insulation. So it makes them very, very difficult to clean. Now, after you've performed the inspection, it's time to package the instruments for steam sterilization. Probably the most common material are cotton sheets, and these are actually very acceptable to use as a packaging for sterilization. One thing you have to be careful of is that you always use a double layer of cotton around the instrument packs. But if you sterilize in cotton, you can store the sterilized packs for about 2 weeks if your storage space is clean and dry. Sometimes you have single-use packaging materials, and these single-use packaging materials should not be reused after they have been sterilized. And the reason for this is that these materials become brittle after they have been sterilized the first time. And when they're brittle, they break very easily, and you no longer have a sterile barrier. And the last common piece of packaging are closable steel drums. And these closable steel drums are quite unreliable because as soon as they come out of the autoclave, they have to be closed, and which means that microbes can enter them before you get the chance to close them. Okay, so what is actually the difference between disinfection and sterilization? The difference is that sterilization kills anything up to bacterial spores, whereas disinfection kills anything lower than that. And we have differences in levels of disinfection. So we have high-level disinfection, we have intermediate-level disinfection, and we have low-level disinfection. Now, low-level disinfection are mostly instruments that only come into contact with the patient's skin. And then you have intermediate-level disinfection, and then you have high-level disinfection. And the high-level disinfection is recommended for anything that comes into contact with the patient's mucus. So high-level disinfection is generally recommended for things like endoscopes. But anything that comes into contact with the patient's blood or sterile tissue must be sterilized. And this actually means that all surgical instruments should be sterilized, preferably by steam. Now, steam should be the main form of sterilization in your hospital. And the advantages of steam are that it has a very high penetrating ability, which means that if there's a little residue still on the instruments, you can still rely that the steam will penetrate through any debris and through small amounts of debris and sterilize the instrument. Now, the other thing that makes steam reliable is that it has very reliable validation methods, which means that we can perform checks on the autoclaves that you have to see whether the process that has been executed has been done safely. Now, steam doesn't require any dangerous chemicals, so it doesn't provide any extra risk to your staff. And to get one misconception out of it is that modern laparoscopic instruments are generally designed for steam sterilization. And you can check this by looking up the instructions for use of the manufacturer of your instrument. Now, instruments used to be boiled for sterilization, but this is no longer recommended because we know that because water only boils at 100 degrees Celsius, this is not enough to sterilize the bacterial spores. So we need to increase the temperature of water, and how we do that is by using a closed chamber. And this is when we started to use pressure cookers to sterilize the instruments. Now, these pressure cookers have been developed, and one of the common autoclaves that we see are gravity-based. And these generally work by having a water reservoir on the bottom, and this water reservoir will be brought to the boil. So this can either be done electrically or even on a stove. And the steam will start to rise, And from the top of the autoclave, the steam will start slowly moving down through the autoclave, and it will push out any remaining air. Now, the other type of autoclave that we have is the horizontal one. And these horizontal autoclaves often have a vacuum in between, or a vacuum before the sterilization starts. Now, what the vacuum does is, instead of like in a vertical autoclave, that the remaining air in the autoclave is pushed out, the vacuum sucks out the air and replaces all of the air in the autoclave by steam. Now, this vacuum is very important in sterilizing laparoscopic instruments because in laparoscopic instruments we have a very long hollow lumen. And the problem with this is that if you have steam that slowly comes down, the steam will try to get into the lumen from both sides, and it will trap air in the middle. Now, the problem with that is that the moisture in the steam makes the sterilization much more efficient. In steam of 134 degrees Celsius, it takes 3 to 5 minutes to perform sterilization. Now, if you have just dry air at the same temperature, it takes about 2 hours to perform proper sterilization. So we need this vacuum in our autoclaves if we want to sterilize the laparoscopic instruments. Now, this is what a typical sterilization cycle of an autoclave looks like. So we have the steam pressure on the y-axis, and we have the time on the x-axis. And what happens is that you close the autoclave door, and it pulls through a few vacuum cycles. And these cycles pull all of the air out of the autoclave. And this air that's sucked out is replaced by steam. And replacing it by steam means that the temperature will rise much more quickly to ensure more quick sterilization. Now, then at the end of the cycle, the autoclave will pull another vacuum. And because of this vacuum, any remaining moisture on the instruments will be boiled off, and this means that the instrument packs will be dry at the end of the cycle. As mentioned, one of the big advantages of steam sterilization is that we can perform proper verification on the autoclave. So we can perform a few steps to see whether the cycle has been complete. Now, what you see a lot is that we put a section of autoclave tape on the outside of the instrument packs. Now, unfortunately, this autoclave tape is not the same as showing that the instruments inside of the pack have become sterile. So the problem is that this autoclave tape comes into contact, as soon as it comes into contact with any steam, it will change color. But it doesn't show that the inside of the instruments or the inside of the packs have also become sterile. So the autoclave tape should only be used to show the difference between packs that have gone into the autoclave and packs that have not yet been gone into the autoclave. Now, the most classical form of a process verification is with something called a Bowie and Dick test. And this is actually quite a simple test that can be performed, but what it is, it's a stack of cotton sheets. And in the middle of those cotton sheets, we have an indicator sheet. So this indicator sheet is quite similar to autoclave tape. But what happens is that we have a bundle of these cotton sheets with the indicator sheet in between. And when the autoclave has run its cycle, we look at this sheet, and only when the sheet has completely changed color, we know that the sterilization was successful. So what this pack of sheets does, it creates a challenge for the steam to reach into. So if this sheet is completely changed color, we know that all of the instruments in the autoclave have come into contact with the steam. Now, besides this test, in some parts of the world, biological indicators are always used as a verification. Now, these biological indicators, they consist of a fluid, and they contain bacterial spores. Now, you put these in the autoclave inside of the instrument basket, and this is one of the most reliable ways of checking whether all of the microbes have been killed, because if after sterilization these devices turn color, you know that the bacterial spores in these biological indicators have died as well. So it's a very good method of showing that the steam sterilization was successful. And the last important thing is that autoclaves always need a yearly calibration. So probably the company that has installed the autoclave for you comes around and does a check on your autoclave to see if it still functions, and it has to be cleaned. It has to, all the lime scale has to be removed from the device. So when maintenance is performed on your device, you should ask the company that comes around to perform one of these process verifications. Now, besides steam, we also have some low temperature sterilization, and low temperature sterilization are often used for pieces of equipment that are either heat or moisture sensitive. Now, there's a lot of different methods of low temperature sterilization. So you should really look into the method that's suitable for you. I now have two common low temperature sterilization methods on the screen here. One of them is hydrogen peroxide and hydrogen peroxide plasma sterilization. Now, this form of sterilization is safe for most instruments, and it doesn't produce any harmful chemicals, but it's a very expensive system to buy and operate. The other common one is ETO, or ethylene oxide, which is also safe for most instruments, but it has a very long cycle time. Now, ETO is a very toxic gas. It's a suspected carcinogen, and it's explosive. And the reason why the cycle time is so long, so it's 8 to 12 hours, is that that's the time that's required to for the gas to safely disperse. Now, the other method that is very common that we saw in the rural hospitals is high-level disinfection. Now, high-level disinfection is occasionally practiced with laparoscopic instruments. And the CDC says that it's an acceptable method when practiced carefully. This careful practice of high-level disinfection makes it so difficult to safely execute, because there's a lot of points in high-level disinfection that can go wrong. And one other big drawback is that it does not sterilize spores. Also, one thing you have to take into account is that instruments that were disinfected by high-level disinfection, they cannot be stored afterwards, because you take the instrument out of generally a wet solution. It means that bacteria will immediately start to grow in the instrument, and you cannot store it. The other problem is that it's very difficult to control and monitor high-level disinfectants. In using glutaraldehyde and Sidex, the manufacturer generally recommends that you can keep one tray of Sidex and it will remain active for 14 days. Now, as I mentioned before, is that when you add wet instruments to a bath of Sidex, this will cause the Sidex to become diluted over time, and with every time there's more dilution, it loses some of its effect. And this effect is also reduced by any dirt or any bioburden that's left on the instrument, and also any other chemicals that are still on the instrument. Now, one of the things if you do use glutaraldehyde, one thing you can use is our indicator strips. So these are strips you can buy, and you can test whether the glutaraldehyde in your tray is still effective or not. And this is actually the only way we can test it. So if you often use Sidex, I will highly recommend getting these test strips. The other problem with high-level disinfection is that there is a big need for sterile rinsing water. Now, in India and probably in some of the countries where you work as well, there is already a problem with access. Now, the manufacturer of glutaraldehyde and Sidex actually recommends that the instruments are rinsed at least 3 times. And not only the outside has to be rinsed, but also the inside. So you can imagine that if you have a long, hollow instrument and it flushes glutaraldehyde up, you also have to get all of that out again. And any residual glutaraldehyde on the instruments can cause quite severe problems for some patients. Now, one area that high-level disinfection could be an option is for single-use devices that cannot be steam sterilized. Now, there's a number of different high-level disinfectants around. I've mentioned glutaraldehyde a few times, and there's some newer ones, some ones that already exist. But what you have to remember is that all disinfectants have advantages and disadvantages. So you really have to think about the purpose of the disinfectant that you use, and think about whether the disadvantages of the disinfectant make it safe to use. Now, the most common method of disinfection that I saw in India was with formalin or formaldehyde. And the formaldehyde is released by tablets that are wrapped in gauze pieces, and they release the formaldehyde gas in these types of boxes. Now, formaldehyde gas has absolutely no advantages for use, and if you can, I would stop using these boxes as soon as possible. This is because it's very, very difficult to reliably operate formaldehyde sterilization and disinfection. The gas is only effective under specific conditions. So, for instance, we need an 80% room humidity inside of the box to achieve sterilization with formaldehyde. Now, what we also saw is that sometimes these boxes were used in between patients, so that the instruments after one patient were cleaned, placed in the box, and then 20 minutes afterwards, they were retrieved out of this box, and the box would be opened multiple times in between. So there's not even time for the gas to properly build up in these boxes. Formaldehyde even needs many hours to sterilize the devices in the first place. So if you leave these instruments for 20 minutes in these boxes, your instruments are just not sterile for use. And one other thing about formaldehyde is that it's a potential carcinogen. So it's very risky to have these boxes in places where you continually work. And the other one is glutaraldehyde or Sidex. One of the problems with glutaraldehyde is that it binds the proteins onto the surface of the instruments. So all of the instruments have to be absolutely clean before using glutaraldehyde. And one other problem is that glutaraldehyde sometimes leads to bacterial resistance. And that, together with some waste that falls off the instruments, can lead to biofilm formation on the bottom or the side of these Sidex tanks. And this has actually led to several hospital outbreaks, and these outbreaks were related back to bottom of the Sidex trays. And as I mentioned before, if you do use Sidex, you really have to test it with test strips to see if it's still effective. Now, some other options for high-level disinfectants that are around are, for instance, peracetic acid, which is a acid-based disinfectant. And this peracetic acid is generally has safe byproducts, so it's not toxic to use, and it's quite fast. The only problem is that it's corrosive to some metals. So especially if you use disposable instruments, it can be corrosive to some of the materials that are on your surgical instruments. And the other one is Cydex OPA. The advantage is that it's faster than Cydex. The disadvantage is that it's much more expensive. So again, there's advantages and disadvantages to all of the disinfectants. I'd like to close with some key messages. Well, first of all, everyone I spoke to in all of the rural hospitals were extremely hardworking, and these hospitals generally have to treat many patients that have to travel a very long distance to look for care. And all of the staff did their absolute best to give the best care available with the limited resources that were available to them. So yeah, some of the key messages that I have are that the question of responsibility of the reprocessing of instruments. So as you might have learned, is that there's a lot of information, a lot of topics about the reprocessing of instruments. And the science behind reprocessing is also growing. So I mentioned this before, but ask yourself, who's going to be responsible for finding new information and finding information on the process that are currently being used. So look for options to train your staff. So even if it's not an option to train everyone, you might be able to have one person trained to that will bring in some new information about the process that you currently use. Develop checklists and procedures for all of the instruments. In that way, you can communicate to everyone what the correct method is to be used, and you can standardize it. And the last one, reprocessing is hazardous. So it's hazardous to staff. So get sufficient personal protection and learn about the chemicals that are being used in your hospital, because that's the only way to learn whether they're being used safely or not. Okay, so last thing is how to find new resources. A lot of the information that I've presented to you today, I have also found on websites of different institutions. So one very good one is guides written by the WHO. And WHO has actually written a very, very comprehensive document that explains all of the steps in reprocessing. And it even describes things like how you should construct a new sterilization department. And also the CDC has some very valuable information about cleaning and disinfection in the guideline for disinfection and sterilization. The last one is the instructions for use, the IFUs. Most medical device manufacturers will have dedicated websites where you can look up information about the instruments that you have, and you can look up what recommendations they make for properly sterilizing them. So then you can look up whether the instruments that you have are safe to put into the autoclave, or that you have to do high-level disinfection on. And here are some other documents which are a bit more specific for laparoscopic instruments. Okay, so that was it. That was my talk. If you're still with me, I'd like to answer some questions. So thank you very much for your attention.
Daniel, thanks for your very comprehensive presentation. Before we go to the questions, I'd like to just highlight two things. One is that generally most of us have the idea that surgical site infection and complications that you're describing are much less in rural areas compared to medical colleges, big urban hospitals. But actually, it's not true. What I've been finding recently is that we don't see so much because the turnover is not much. Even in rural areas, surgical site infection varies from 6 to 10%. And if you do only, say, 10 surgeries in a month, you'll hardly see one patient. While in a medical college where they do 10 every day, they see the complication more often. So the surgeons there remember the complication much more frequently than other places in rural areas. we don't see so much complication because the turnover is not there. But then the incidence is almost the same. So we need to take similar precautions as in medical colleges, big hospitals. And the other thing is that we talk quite a bit about checklists and SOPs. It's good to sit and write all of them. But unfortunately, my finding is that most of the time, unless there is a person to supervise whether people are following it, it does not get followed. So if you have a checklist, you have to remember that you need to allocate somebody. May not be a medical person. Somebody in administration who needs to sort of supervise whether these things are being carried out. Unless that is done, then it's not really much of a help just having the checklist. Because once you follow it, then it makes sense. If you don't follow it, it doesn't make much of a difference. And probably now with the pandemic, I think people will start wearing face shields and a lot of other things that you were describing, which probably may in one way be a helpful thing. And there was a question about heat sensitive and heat resistant things from one of the viewers in LabGuru. Can you answer that if they want to know?
Yeah. So any device that is heat tolerant should ideally be steam sterilized in the autoclave. The heat sensitive things are more complicated, and that's when the high level disinfection or low temperature sterilization comes in. Now, probably in rural settings, low temperature sterilization methods will be less available because they're very expensive devices. So then you'll look into solutions like Sidex or peracetic acid for disinfection. But then you really have to take into account the monitoring of those solutions.
What about peracetic acid? We don't use, I have not heard many people use peracetic acid. Many of the places we often use only glutatiate. Is that any advantage of using peracetic acid? Or?
I think there is. I'm not exactly sure how you use it because I'm not too familiar with it myself, but it seems to be quite effective as a disinfectant. The only problem is, as I presented, is that it can be corrosive to some materials. So it will eventually dissolve materials like aluminium or brass.
What about stainless steel and the usual material that we have in laparoscopic instruments?
For stainless, it's okay. For plastics, it's also, but you have to be careful because it's a very, very strong acid. So if you want to use something like peracetic acid, you have to invest in good protection. So you have to use gloves, and probably you have to have a well-ventilated area as well.
Will that also be helpful in act like an enzyme to dissolve the biofilms, and would that be better than Sidex in clearing the biofilms?
I think some of the properties I've seen do show that it's better in dissolving proteins as well. You still want to properly clean the devices, but yeah, I don't have too much experience, so I don't know if you can use it the same way as Sidex, so you can just open it and soak instruments in it. But some of the resources that I've presented, so the WHO or the CDC resources, give some information on peracetic acid as well.
And there's another question from one of the viewers in LabGuru about atypical mycobacterial infection. That's one of the commonly published infection with laparoscopic surgery. What is your the recommendation for best for tackling atypical mycobacterial infection?
Well, I don't know too much about treating it in patients, but if it's a
recurring patient for instruments,
yeah, if it's a recurring problem, definitely steam sterilize your instruments. If you're not able to steam sterilize your instruments, make sure that that you check the Sidex with Sidex test strips to see if that's effective. Make sure that you clean and sterilize your Sidex tray as well. And make sure that the rinsing water that you use is also fully sterile. So sometimes that we see is that not only the Sidex gets left for a long time, also the rinsing water for the Sidex gets left for a while. Now the Sidex might be sterile for 2 weeks, but the rinsing water definitely isn't. So I would look into that. So number 1 is steam sterilization. Number 2 is clean your Sidex tray, test your Sidex, and use clean rinsing water.
So the rinsing water, is it sufficient if we just boil the water and cool it? Is that enough, or do you like little more treatment on that?
Well, boiling doesn't kill bacterial spores, so if you boil it, it won't be fully sterile.
Or if you put it in in autoclave or something like that. And
you can autoclave liquids, but I've only seen it in small amounts. So mostly what happens is that you buy commercial sterilized water, but I understand that.
No, like what about how you make alcohol? You make condensed steam and get that. Would that be better than just plain water?
Yes, condensated water should be fine. I think if you have a good source of reverse osmosis water, so RO water, that's also good.
So a question, Daniel.
Yes.
Yeah, so for us, we often use normal saline to rinse once the laparoscopic equipment comes from the Sidex. Would that little saline destroy it? Because you mentioned that saline should be bad.
If you use saline for rinsing, I don't think it's a problem because mostly you rinse it and you use it directly on the patient. So for rinsing, it won't destroy your instruments. But one of the things that we've seen is that if you rinse with saline, the nurses are quite careful with it. So they use very little. And it's very hard to fully rinse the whole instrument to get off all of the Sidex. So that's the objection that I
a lot of places what they have a separate drum or filled with water or saline. They soak it first and then also in addition use normal saline for rinsing. So that might help.
Yeah.
Okay. Thank you.
But I think saline is very sterile, so it should be okay to rinse the instrument.
But expensive.
It is expensive, yeah. So maybe it would be cheaper to commercially buy sterile water for the rinsing.
Right. Thank you.
Okay, then. Thank you. Thanks.
We have another question, sir. It's from a lab group viewer, Dr. Ashwini Kumar Jalewa. He asks, what about UV sterilization of water at inlet?
Not too experienced with UV sterilization of water, so you'd have to look that up. Look up whether UV sterilization not only kills bacteria, but it also kills bacterial spores. That's what you'd have to look into. But I think it's a very good suggestion. So I'll.
My feeling is that it doesn't affect the spores. It kills the viruses and the bacteria. And again, we need to know the contact time that is necessary for it.
Yeah, so that would not make water sterile with the UV. Okay.
Okay then. Thanks everyone for joining. Have a great day.
Thanks, Dr. Nanraj.
Thank you very much. Thank you, Daniel Robertson, for the wonderful presentation. And
thanks everyone for your attention.
Thank you to all our participants for joining today. We'll end the session now. Thank you.
Thank you.